with our amazing speakers and the Cornwall Hospice team. So just to reiterate a couple of housekeeping points, can I ask that all cameras stay off unless you're presenting, and your microphones stay off as well, please. Any comments or questions into the chat box, and we will try to pick up as many as we can. However, as you will see, there's a lot of people on today, so anything unanswered we will pick up and share with the presentation and the certificates after the event. Just to note, by joining the meeting, you have agreed to us recording it and sharing it, and there will be a bar showing that the recording has begun. If there are problems with viewing any of the presenters, since that we are in meeting mode rather than live, it tends to be that the speaker will take the whole page, but you can pin a speaker by hovering over their name at the bottom left. And if you can see the 3 dots, they will have the option of pinning and unpinning. Lolly is going to be posting a survey monkey in the chat box to evaluate the seminar afterwards, and we would really appreciate you giving as much feedback as possible so that we can make the next one even better. And this would also go out as well with all of the post-seminar information and recordings. We obviously want to be trending in this important week and around this important conversation. So if you do have social media networks, please share hashtag EOL Cornwall for any social media, and also for Dying Matters Week. And I can't remember this one, but somebody did send it to me kindly just now. There is a hashtag which is DMAW21, Dying Matters Awareness Week 21. So please share that widely if you can. And Tracy's actually put that in the chat as well. So thank you for that. So I don't want you to have to listen to too much of me. We're going to be starting with what matters, setting the context of what matters to patients with advanced incurable conditions, symptom control, meaningful information about their illness, plans and preferences for the future, family support and coordination of care between care settings. And leading this important session is Dr. Jane Gibbins, who is appointed consultant in palliative medicine at Cornwall Hospice Care in 2013. And we really look forward to your session today, Jane. So over to you.
Thank you very much, Nikki, and good afternoon to everyone. My name is Jane Gibbins. I'm a palliative care consultant and I work across care settings. So I work in the acute hospital, I work in the community setting and with the hospice too. And I work with our nursing staff and extended multidisciplinary teams to try and give the best possible care to patients who've got advanced incurable illnesses and when they're dying. Thank you for asking me to talk today, Lolly, and to the extended team for organising this wonderful event this afternoon and tomorrow as well. So medicine is just a very small part of death and dying and being at the end of your life. It's a spiritual, relationship, emotional and societal concept, and it's going to happen to all of us at some stage. However, the things that are important to patients will transcend medicine and the societal aspects of death and dying, and that's what I'm going to talk about today. I'm going to focus on the patient aspects and what is important to them and their families. So if we could start the slide session, please. So next slide, please. So I'm going to talk about what matters to patients, what palliative care can do to help those patients, and to think a little bit about the demographics of death and dying for us to set the scene for this afternoon and tomorrow. Next slide, please. So I'm going to start with a hypothetical question and concept to you when considering what's important to patients who've got advanced and incurable conditions and those that are dying. I want you to imagine that yourselves or a close relative is diagnosed and they or you have been told that you've got approximately 12 months to live. Now, this is very hypothetical because in healthcare we tend not to give people accurate prognostications, but I just want to use it as an exercise to think about what would be important to us if that happened to us or our loved one. So what matters to them? What's important to them as individuals? And that might vary. For me, it might be my family being with me, getting some photographs out, making sure that I've got mascara on. But to my husband and my children, it might be very different things. And I want you to put those individual things to a side at the moment and think about, what do patients need from us as a society, and more importantly, in the healthcare setting? And if you start to put some of those ideas and concepts in the chat, then we can start to think about those. Next slide, please. So the literature, which is based on talking to patients and healthcare professionals and lots of other studies, suggests these are the 5 key aspects that are important to patients. So some patients may have an incidental finding of an advanced incurable condition, so they may be asymptomatic. But we know for lots of people in their last year of life, they will have symptoms, whether that's pain, breathlessness, anxiety and distress, or overwhelming fatigue. We also know that patients and their families need essential information to be able to plan the next part of their care. So we sometimes call this breaking bad news or unwelcome news, but I see it as essential news. It's essential for them to work out what's important to them. So it might be that the chemotherapy is here to prolong our life by a little bit. It might be that we think time is really short, so that they can then plan for the future. They also want our priorities and preferences listened to, but that we do something about it. So if we talk to them about wanting to come in and out of hospital or not, or if we talk to them about where they would like to die, or if we talk to them about needing to have a conversation with their loved ones in Australia, they want us to listen to that, but they want us to then do something about it. And I can see from the chat that you're all talking about these things. So these are the things that we can all identify, although it's not happening to us at the moment. So you're talking about focusing on living, you're talking about dignity, we're talking about family support and being together with our family, and also quality time. So to enable all those things, we need well coordinated and integrated services across Cornwall or wherever you work to provide that care for patients at the end of life. And that means that if I have seen a patient who's had a very sensitive conversation with me, I need to share that with my community colleagues, the GPs. I might need to share it with the oncologist. And lastly, but by no means least, they want to ensure that their family are well supported, and we try and reduce the burden for their family. So all the things that you've been discussing in the chat. Next slide, please. So I see this like a jigsaw puzzle, and jigsaw puzzles don't really work unless you've got every piece of the jigsaw puzzle there. And I'm going to explain these concepts in terms of a patient so that we can put this into real in everyday life. So that might be a 35-year-old lady that's now got metastatic breast cancer, so she's going to die of that at some stage. She might be referred to the GP or my team or the hospital because she's got acute symptoms. She's in a lot of pain, she's breathless and she's panicky. So we need to sort that out for her because that really matters to her. However, if I just look at the pain, the breathlessness and the panic in isolation, that's not going to give her the optimal care. So I need to talk to her to see if she's got any information or essential information needs. And most of the time they will have questions they haven't been able to ask other people. So for her, it was a conversation around, should I continue with chemotherapy? Is it the right thing to do? I'm having lots of side effects from this. And is it really going to improve my length and my quality of time? And then within that, we started a conversation about CPR and resuscitation. Within that, I also need to think about what's important to her. And we broached on the concept of considering plans for the future, but she wasn't able to do that until her symptoms were better. I then need to make sure that I have a well-coordinated service for her. So the conversations that she's had with me about her chemotherapy, I need to talk to the oncologists about, and I need to make sure that everyone in the community is aware. And lastly, but by no means least, our family are always dear to us. So she wanted to get married. She wanted to think about how she was going to talk to her children about this. She was worried about how her mum and dad were going to cope with the death of a child. her, and she was worried about the genetics of breast cancer for her sisters. So if I had only focused on one of those 5 bits of the jigsaw puzzle, it wouldn't have worked for her to enable her to get the best possible care at the right time in the right place. Next slide, please. So what is palliative care and how can we help? Well, you can see the WHO definition there, which is essentially all the things that I've already talked about, those 5 key areas. But the models of palliative care are changing. Traditionally, we would see people at the very end of their life, their very last days and weeks of life. But now, more modern, futuristic models are appearing. So we have flexible services whereby I may see someone at the very beginning of their diagnosis when they may have 10 years to live because they've got complex pain. I may see them again in a couple of years' time, or I might need to see someone in their very last days of life. There's also the concept now of palliative care running alongside other specialities, and that's early palliative care. And there's some great evidence that I'll talk to you about in a moment that have come out from the United States about that. And there is now a new concept called enhanced supportive care. Some will argue whether this is palliative care or not, and whether it's a different service, but it's essentially highlighting people that might benefit from palliative care and extended services. Next slide, please. I'm sure that all of you in the room know that this isn't what palliative care is because you're here and you're engaged in this topic. But many people that I meet, both in my profession and socially, when I talk about the terms palliative care and hospices, they think it's only about death and dying. Yes, death and dying is important and is part of our role, but we actually focus on quality of time and length of time, as well as the last days of life. People also think that we shorten people's lives or we hasten death, and we definitely don't do that, and there's studies out that support that as well. Next slide, please. So how do hospices help with this? Well, the hospices are facilitating this session today, and I'm very grateful for Cornwall Hospice Care to do that. They do a lot of education. But in terms of patients, they're generally a place where people will come in terms of a crisis, and that's normally around symptom control, but it might be that they've got severe psychological distress or they need a multidisciplinary approach. So we look at their symptoms and those 5 key aspects that are important to patients, and it's normally in a time when they can look at what's important to them, what matters, what their goals, what are they concerns about, so they've got time to support, consider the future and learn, enabling them to be able to do what's important to them. Some patients will come into the hospice to die, and that will be their preference for their place of dying care. And for about 50% of patients that come into the acute hospice will die there, and the other patients, 50%, will go home. Next slide, please. I think that we sometimes in medicine don't always focus on quality of life. And lots of the time in my job, I spend my time convincing healthcare professionals and patients that the hospice might be a good place for them to go at this stage in their illness. And we've got some really good data now. I'm sorry, my dog just barked. We've got some really good data from Cornwall Hospice Care that enables us to look at that improvement in quality of life. So if you look at the horizontal axis, that is looking at quality of life score as by the patient's perspective. So 1 being poor and 8 being excellent. And on the vertical axis, you've got the number of patients that are responding to that. So pre is the patients a week before coming into the hospice, and post is a week after they've been in the hospice. And what you can see here really clearly is that the blue diminishes. So the blue from poor quality of life is very high at the beginning, then it goes down low, whereas the excellent, we can shift people's quality of life in the hospice. And I think that even though we haven't got the data on that in other care settings at the moment in Cornwall, I think that we do that in other care settings from a palliative care perspective as well. Next slide, please. And that's because we live by this mantra. We live by this mantra of Dame Cecily Saunders, who was a trained nurse, a trained social worker, and then a trained doctor, that felt that care of the dying wasn't great in the 1960s. So she pioneered the hospice movement to try and improve that. And she explained, you matter because you are who you are, and you matter until the last moments of your life. We will do all that we can to help you not only die peacefully, but live until you die. Next slide, please. So what's the evidence? I can stand here and talk to you and say that palliative care makes lots of difference to patients, but what evidence do we have that suggests that? This is a trial that came from America, and it's quite old now, but it's really, really key, because lots of patients and relatives and healthcare professionals are scared of the term palliative care, and they think that it means you're dying, or that we are going to shorten your life. But actually, what this study showed was really exceptional. Does anyone know what this study showed? Does anyone want to put their hand up or write it in the chat? Okay, next slide, please. What this told us was that if you engage in palliative care services, you have a better quality of life, you have fewer depressive symptoms, and you actually have longer, not shorter survival. Now, we don't know why that is, but that's what the data showed. So they took a group of patients that were having oncology treatment, so chemotherapy, radiotherapy, and they took another group of patients that had that same treatment, oncology and radiotherapy, with palliative care as well. So this gives us an idea of what palliative care can add to someone's care. Next slide, please. But we don't just deal with patients that have cancer. Not all of us will die from cancer. A lot of us will die from a non-malignant, non-cancer diagnosis. So this gives us an example of another case whereby a 56-year-old gentleman who hasn't even yet got his diagnosis of motor neuron disease, but is likely to have this based on his clinical presentation and seeing the neurologist, was referred to us by the neurology team. He was in extreme pain. He was extremely breathless, and his bladder and bowels weren't working. And this was causing him high distress in the acute hospital setting. But if I'd just seen him and dealt with those symptoms, I'd have missed another 80% of his care. So he had real information needs, or essential information needs, about his diagnosis, and we were able to talk to and hold the uncertainty around that. And within that conversation, he felt that his previous IV drug abuse had led to his illness, which of course it hadn't, so we could reassure him about that. He was able to be very clear about what his preferences and plans were, and he said that he wanted to keep dignity, and that for him, dignity was about his bladder and bowels. To enable continuity and coordination of services, he actually went over to the hospice for symptom control, for family support, for a multidisciplinary approach. And alongside that, while his diagnosis was still being made, we communicated very closely with the neurology team to see if there were other offers available. So, for example, did he need some ventilation at any point, or did he need any artificial feeding? And in terms of his family, we've been able to do some pre-bereavement support in terms of he doesn't want to be a burden for his family, so thinking about the optimal place of care for this gentleman and how his family are going to cope when he dies. Next slide, please. So let's put all this into context. What do most of us die from? Where do most of us die, and who is going to care for them? Next slide, please. So the majority of us won't die from a sudden illness. The majority of us won't die from an acute heart attack, acute stroke, a road traffic accident. The majority of us will die from a chronic condition, whether that's cancer, heart failure, respiratory problems, dementia, or chronic frailty. And because it's not an acute, sudden event, we can use all those 5 bits of the jigsaw to enable the care for that patient to be the best it possibly can be, and for society to consider the implications of this. Yet, even though most of us don't want to die in hospital, about 60% of us do. And that's another discussion in itself. Next slide, please. So in terms of Cornwall, and I know there's lots of people from outside of Cornwall, but to put all this into context about what matters for people when they're unwell. So for someone in Cornwall, they may live in Land's End or they may live in Boscastle, and they might want their primary care to be delivered as close to home for as long as they possibly can. So they may be at home. They may need to access a community hospital. So these little blue spots represent all the community hospitals that we have here in Cornwall. Whoever's doing the slides, can you just press enter, because there should be some more blobs come up. Brilliant. However, these blobs have changed a little bit on here, so I'm sorry, but these big red spots signify the acute hospital. So there are times when patients will need to go into the acute hospital, and that's exactly the right thing to do. They may need treatment for a spinal cord compression where their nerves are being compacted by a cancer, or they may need a stent to enable them to swallow. So there are times when they will need to be in the acute hospital setting. Another return button, please. There are also community teams. So there's 3 teams within Cornwall who work in the north and east, the central and the west. There are community specialist palliative care nurses that try and keep people at home for as long as they possibly can. And lastly, but by no means least, next blob, please. Those are the MTTs that supply them. And then we have 2 hospices. So we have one in Hale, and I'm sorry, thank you, Kirsten, for saying about the community hospitals. I know that's not acute hospitals. I think it's just because the blobs have been moved location within that. But we have 2 acute hospices, which one in St Austell and one in Hale. Next slide, please. So in summary, I hope I've just started to open the box about what's important to patients, what's important to us as a society in caring for people who are at their end of life. And that is us all working together, whether we are working in medicine and allied healthcare professionals, whether we're working in social care, whether we're working in the CCG, enabling commissioning of these services, or whether we're informal carers, is to think about symptom control, essential information needs, looking at our preferences and plans for the future to enable that care is well coordinated, and that we try and reduce family burden and that they're well supported. Next slide, please. If you've got any questions, please don't hesitate to answer them. And these are my contact details, so please feel free to contact me at any time. And I'm sorry I haven't been able to see everything that's on the chat, but I will go back and have a look at that now. Thank you.
Thank you so much, Jane, for really thought-provoking presentation, as people have been commenting in the chat. And I'm just going to pick up some comments for you. People talking about a bucket list of things to do, not being in pain, and last goodbyes with everything financially in place. Contact with other patients who understand and not needing to be worrying about hurting others by having difficult emotional conversations. Also talking about within what we define as family, and actually kind of how people see that, and someone has mentioned within the LGBTQ community. So thinking about, you know, who we identify with, I guess, and what. So lots of comments coming into the chat there. I wanted to just ask you as well, as a couple of specific questions. How valuable do you see the end of life care passport in helping to support that kind of whole approach to palliative and end-of-life care? And then also, what do you think are the opportunities now that we're moving forward with integrated local care areas for everybody to actually wrap around the patient and the family, wider community and friends in our new world as we go forward?
Thanks, Nikki. I think those are 2 really important questions. So the Cornwall passport, the education is key. In palliative care, we're not going to see every person that's at the end of the life and who are dying. And I'm extremely passionate about this, having done my MD around how we prepare junior doctors to care for patients that are dying. So education for any healthcare professional is absolute, and we're not going to improve end of life care if we don't do that. So I think Cornwall are ahead of the curve by having that there available, and I would encourage everybody to take part in that. And I think that education can be formal, but it can also be very informal. A lot of it is about taking the opportunity to watch people that do this every day as part of their job to say, well, how can I do this? How can I do this better? I like the way that this person's done it. I'm not so sure about that. or asking a palliative care team to come along with you during an essential information session, or breaking net bad news or unwelcome news, so that we can get that the best that we possibly can. The second question is around integrated care, which I'm also extremely passionate about. We can't work in silos anymore. It doesn't work. It means that we don't give optimal care for patients with the resources that we have. And so integrating our services and our care as optimally as we can is key, so that we can prevent the 20 ambulances that are outside Trelisk at the moment, because people are so sick and need to go into hospital. But at the same time, there'll be lots of people that need to get out of hospital and want to be closer to their home. I'm really proud to say that as a group of palliative care consultants, we're an extremely low resource in Cornwall. There are 3.5 of us, whereas we should have 7 of us, whole-time equivalents, and we work integratively. We work in the community, hospital and the hospice, and we have to, because there's so few of us. Otherwise, it means that one of those care settings wouldn't have care from our team, and therefore it wouldn't work. So I think integration is key. And then the third question, I think, was around that kind of what they've done in Froome, and I can't think the word of it at the moment. Compassionate communities. Compassionate communities are key. We know that we've got the patient in the centre, and we've got that ripple effect of everything coming out. The person that's helping the husband to provide food to their family while their wife is dying, or the granny that's providing some emotional support, or the chaplain that just comes in and makes sure that they're all okay. That is key. It can't work without that.
Thank you, Jane. That's really helpful, and I could keep you here all afternoon, but I'm just going to mention one more thing. So someone has actually asked a question, which is Kirsten has just said, when you talk about integrated care, does this include coordinate my care, where everyone can create their own care plan?
Thank you, Kirsten. Yes, so my understanding is that Coordinate My Care, which is an electronic platform produced by Julia Riley, one of the consultants in Marsden, is coming to Cornwall. I don't know the timings of that, and I suspect Trudy Raymond, who's here, might be able to give us more detail on that, but it's absolutely that. We haven't got a coordinated IT system at the moment, and that's why lots of things, people do lots of great work, but that work is then lost. And so if we can have a system where we electronically record that, so it might be that the paramedic that sees a patient at 2 o'clock in the morning can see that they've got their resuscitation status documented, and it might be that they don't need to go into hospital. What actually they need is someone to sit with them and help them while they're having a panic attack. That will help with that.
Thank you, Jane. There is a question, but we are running out of time. But just in terms of the end-of-life care passports, somebody has actually also uploaded kindly something about mywishes.co.uk, which is a free resource. What I would suggest, if it's okay with the end-of-life care passports, is we'll send out some follow-up information to everybody, just to say how you can connect and how you can take part in that training. And I'm just going to quickly finish off with one more question, and that is based on a personal experience recently. Is just seeing how social media, Jane, is being used by patients, not all patients, obviously, because it's a personal journey, to reach out to friends and family in terms of taking a positive journey. So a step-by-step, almost like online journal of their whole journey, which is another way people seem to be raising awareness of palliative care and people and professionals' roles in that, and just how much local communities then get behind that person, either in terms of fundraising or just moral support. And also being able to connect more with the family. So I also just wondered, in this digital world that we've come into in COVID as well, how do you see that playing a role in palliative care in terms of, I suppose, communication going forward?
Yeah, I think it's key, Nikki. I think that for a long time, death and dying, palliative care, hospices have been a huge taboo. I know that there's lots of negative connotations with social media, or there can be, but I think this is a platform where it could be extremely positive And I think it can be positive on a individual basis. So actually the patient that I described earlier with breast cancer, that's one of the things she told me. She said, I have had to put this on social media. I've put it on Facebook because I want everyone to know in my village when I come back why my life might be different now, and why having a newborn baby here isn't quite as it was going to be because I've got cancer too. So from an individual basis, I think it can be really powerful, but also from a, you know, making things change. I was listening to a discussion this morning about palliative care and how smoking changed because of people saying this isn't acceptable anymore. It's not acceptable for us to be smoking in public places. Why are we doing this? And 40 years ago, we'd have never expected that change. But that was about social movement. And I think palliative care could be a platform for that as well, and getting rid of the taboo that we have around death and dying, because it's huge.
Yeah, absolutely. Thank you so much, Jane. It's been a brilliant session, and all of the information that Jane has shared and some of the questions that have been in the chat will also be shared with Ruddy after the seminar today. So thank you ever so much, Jane. I just want to check whether or not we do have Sarah here, just to double check, because we couldn't see Sarah on the chat.
Yeah, I'm here.
Hello, Sarah. Thank you so much. That's okay. So I want to quickly introduce what you're going to be talking about, which is advanced decisions to refuse treatment and treatment escalation plans. So Sarah Ashley is a portfolio doctor who works for Cornwall Hospice Care. She spends most of her time at St Julia's Hospice in Hale and is also a part-time GP, having spent more than 10 years as a GP in Camborne. So welcome to you, Sarah, and really look forward to your presentation.
Thank you. So I've been given 15 minutes and I've been told that this is aimed both towards lay and medical professionals as well. And it's a massive topic to cover in 15 minutes in a way that's meaningful to everyone. So I do hope this means something to everyone as they go along, but we'll see how we go. It looks like I've got lots of slides and they are going to be sent out afterwards, and I put some hyperlinks on some of the slides which will enable you to find some more information, hopefully. So we're talking about, are you guys going to be doing the slides forwards for me? Thank you very much. So can you go to the first slide? So ADRTs I'm going to talk about first. They're also called advanced decisions or advanced directives, sometimes living wills, but not advanced statements or advanced care plans, which will both be talked about a little bit later on. So we won't talk about those bits, we'll just talk about decisions, directives and living wills. Next slide, please. So the first thing I wanted to do was just put up a little cartoon that makes me laugh when one thinks about advanced decisions. As we'll go on to discover in the next few minutes, hopefully you'll realise that advanced decisions are much more than what Dogbert thinks they are. Next slide, please. So they are actually evidence of your decision to decline treatments which would medically be in your best interest. So things like CPR, ventilation, feeding, fluids, blood transfusions and antibiotics. It's also your choice to decline life-sustaining treatments when you've developed specific illnesses. So things like motor neurone disease or dementia, or in situations you might feel would be intolerable, like being persistently unaware of what's going on around you, persistently agitated, unable to interact with other people. Next slide, please. So the first question, are they legal? That's really important to think about. And the first thing to say is they are legally binding, but only if certain conditions have been met, which we'll go on to explore in a second. The most important thing to be aware of is they only come into force if you lack capacity. So if you're able to clearly explain what you want and you have the capacity to make those decisions, your ADRT cannot supervent your feelings. So if you feel something different to what's written down and you can express that and you have capacity to do that, your ADRT won't come into force. Now, if you don't have capacity, but you had capacity when the decision was made, then it is certainly legally binding, as long as you have specified the situation arising. And that's quite ticklish because actually you need to be really specific about the situation that's arising in order to make the ADRT enforceable or kind of legally binding. and we'll talk a little bit more about that perhaps in a minute. It also needs to be signed by yourself and witnessed if you're wanting to avoid life-sustaining treatments, and need to include the words, even if my life were at risk. So that's a really important bit of making sure that it's legally binding. And you also need not to have done anything to contradict it. So, for example, if you said on your ADRT that you didn't want a blood transfusion, but since it's signed, you'd actually had one, that would contradict your ADRT. So that would suggest that you weren't feeling the same as you were when you actually completed the form. Thank you very much. Next slide. So what can you not use an ADRT for? You can't make general statements of what you want. So you can't say, no, I don't want to be alive if this happens. You need to be really specific about what you want. You can't use an ADRT to refuse basic hygiene kind of care, those kind of basic care things. You can't use an ADRT to request anything specific. Particularly not clinically inappropriate things or illegal treatments, but you shouldn't really be using it to request anything at all. And you can't use it to appoint anyone else to make decisions on your behalf. That's LPAs, which I believe we will also be talking about shortly. Next slide, please. So in terms of practicalities, again, there's a couple of hyperlinks down the side to various different forms. The best known example of that people often talk about, and possibly the most hotly debated one, is the Jehovah's Witnesses, who have often make advanced decisions to refuse blood transfusion. But in terms of thinking about autonomy and self-determined care, which we're talking about what matters to you at the end of life, more and more organisations like Compassion in Dying, like the Bereavement Advice Centre, are putting together pre-prepared sample forms that you can complete. And you don't have to use a pre-prepared form. You don't have to kind of do any particular type of form, but to use one of the forms will enable you to make sure that you can prepare your wishes specifically enough for them to be enforceable or kind of usable, and also remind you of the wording you need to use and the fact that you need to have it witnessed. So things like making sure it says, even if my life were at risk, and those kind of forms, as I said, do have a look at them later on, can remind you all the things that you need to say. Thinking about advantages and disadvantages, certainly having an ADRT can promote patient-centred, preference-sensitive care. So the things that you want to happen to yourself when you want them to happen or when you don't want them to happen. It enables you to be clear about what you want, and it can take the pressure off a family and the healthcare team around certain decisions that you might prefer to refuse if it comes to it. But in terms of disadvantages, because it needs to be so very specific, it can be quite hard to get it to actually be absolutely applicable in the situation. So should you make one? Because it's very patient driven, it's very much up to the individual patient as to whether they make one. If you think that you are feeling very strongly about particular types of treatment that you wouldn't want to have in any particular circumstance, you really should make one, because if you don't have one, the medical team will act in your best interest at all times. You should tell your nearest and dearest, and it's really important that the people around you know that you've got one, because actually the forms can only say what they say, but you can fill in the gaps with the ones you love, because if your form is not specific enough, if your loved ones know what you want, then actually it will enable them to ensure that your wishes are fulfilled. You should also let your GP know and perhaps discuss it with your GP. And if you have a regular medical input, so a community matron or a CSPCN, you should make sure that they know as well. It needs to be somewhere left really obvious. So if you're housebound, making sure that it's somewhere where if a medical professional comes into the house, they'll find it. If you're mobile and out and about, it's really important to take it with you, particularly if your wishes would be relevant when you're out and about. And if you change your mind about having one, you can just remove it and don't carry it around with you, because actually if you change your mind and you want to have all of the treatments that you previously didn't think you would want, the team will just give you the medical treatment that's considered in your best interest. If you wish to put more treatments on it, just go through the process of creating a new one with your new wishes on them. Lovely. So next slide, please. My next question, is an ADRT a TEP? Well, I've kind of put yes and no, because it sort of, they can sound quite similar. So the treatments and the situations that are covered in a TEP form can form part of your wishes on an ADRT. But unlike the ADRT, which is patient-driven and patient-organised, the TEP form, or a treatment escalation plan form is usually clinician-initiated following a clinical discussion and consideration of whether you're likely to deteriorate and your heart's likely to stop, or you're reaching the end of your life within the next 6 to 12 months. Often people in the medical profession talk about the would you be surprised if this patient were to die within the next 6 to 12 months. So completion of a TEP form, a treatment escalation plan, should ideally be with the medical team who are looking after you, so you as the patient wouldn't need to do anything in terms of signing or witnessing it. Can we have the next slide, please? So the next slide is a photograph which I took a few years ago when we were at Disneyland Paris with the family. And when I saw this, I thought somebody clearly has a sense of humour or a sense of irony in their design planning, because this encapsulates what the public think about treatment escalation plans. Because it comes from the idea of do not resuscitate. And it's portrayed as the patient can either have resuscitation and they can live as a result of having resuscitation, or they can choose not to have it and they can die as a result. But we're going to go on and just explore very briefly CPR and do not resuscitate on the way to treatment escalation plans, so that we can see that actually thinking about the treatment escalation plan can enable you to die in the way that you want to. So very briefly, CPR, or cardiopulmonary resuscitation, was first described centuries ago and wasn't really very successful until it came to the 60s, when the treatments were developed that could effectively restart and stabilise a heart in somebody whose heart had been disrupted. It's only ever meant to be a stopgap to maintain basic function, CPR, until a normal heart can be stabilised. It's never a way of reversing the dying process. But because it was really simple, when it was first introduced, it was offered to everyone, or it was automatically done for everyone in hospital. But by the late 60s, there were lots of reports about people becoming, having lots of injuries, brain injuries, kind of rib injuries, and undergoing a death process which was really unpleasant for the patients and for their families as well. So a process started initially kind of covertly amongst the medical teams, but increasingly formalised as a form, which was initially described as a do not resuscitate form. So can we have the next slide quickly, please? So the next slide has lots of different terms that have been used for this kind of process, the CPR treatment escalation process. But using terms like do not resuscitate can have a really difficult issue from a medical point of view, because resuscitation is more than just cardiopulmonary resuscitation. And also thinking do not resuscitate can often give an impression to patients or relatives that something is being denied to the patient that would otherwise be successful. Now, just very interestingly, if you look, and there's a link at the bottom to a study about perception of cardiopulmonary resuscitation, and apparently the majority, so 70+% of lay people assume the success of CPR is about 75%, whereas in an otherwise healthy person it's about 10%, depending on the reason for arrest, and that reduces to 3% or less in the over 80s and 1.9% of secondary cancer patients. So actually it's really not very successful as a process for somebody who's otherwise unwell. So the terminology changed to say do not attempt resuscitation, so that it was clear that we weren't promising we would be able to resuscitate someone as a medical professional, and moved on to thinking about allowing natural death. But again, natural death has strange connotations. If you think about natural death in the way you think about natural birth, it might suggest that somebody didn't want to have drugs or kind of medical interventions to make their death a more comfortable process. And they're now called POSTs in the US. They're called RESPECT, which is the Resuscitation Council option, and treatment escalation plans, which are a Southwest thing, which were introduced in about 2006. Can we have the next slide? And a treatment escalation plan is so much more than just DNAR. or do not resuscitate. And there's copies of the form on the hyperlinks there that you can get later on. But it covers things like admission to hospital, administering fluids, antibiotics, feeding, pacemakers, going to ITU, and also the would you want to have or, is cardiopulmonary resuscitation appropriate or not for this patient? Which goes to kind of show that actually what you're thinking about is not just what you're wanting to try and encapsulate is what the patient wants and what is most important to the patient. Next slide, please. I'm aware we're going through this really quickly. I'm so sorry. In terms of practicalities, advantages much like ADRTs, there's a real opportunity to open discussion with patients and allow a patient-sensitive, patient-centred form of management. But it can be really difficult. And when you start to open up a tech discussion, particularly if people haven't thought about it before, it can cause a lot of distress. Just because we're talking about, what happens if you become less well doesn't mean that you're going to become less well. And I think sometimes people worry that if we start to think about it, suddenly they're going to become less well and die very quickly. And also, sometimes if you start thinking about CPR, people might feel that if you say no, you're shutting the door to all of those other forms of treatments. I put the term legalities there. Just to think about, are they, the legal side of them? It's worth remembering that the patient's request doesn't supersede a clinical judgment. So a patient can't demand to have CPR, but we as a medical team have a legal responsibility to inform the patients if we feel that it's clinically appropriate for a TEP form to be completed. I.e. if we feel that CPR doing resuscitation on the patient would be unkind or futile, we should be talking about that with them. Oh my goodness, did you hear that? It's just me. If it's just me, I'll keep talking.
Oh, it's okay. I can hear you again now.
You can hear me again now. So as a medical team, we have a really important kind of role in talking to the patients and discussing with them why they feel if they want resuscitation where we feel it would be inappropriate. We need to discuss with them, find out what they're feeling with an aim to reach a consensus. If we can't reach a consensus with a patient, we should be seeking a second opinion with another clinician of a consultant status to make sure that the patient is appropriately advised. We don't always have to discuss it with patients if they don't have capacity, or if we feel it's really unwise to do so, we can discuss it with families and next of kin, but there's spaces on the form that we need to make sure that we clarify who we've spoken to and what we've said in terms of conversations. That was a really quick, I'm sure lots of people have lots of questions about those. So should you have one? If you feel that you want one, it would be really important to discuss it with your healthcare provider, and that can be quite an interesting conversation to have. I've just done this with my great aunt who didn't want to be resuscitated, so I would recommend doing it with a GP for relatives if they would like to have it done, or if they would like to kind of have that element of their care thought about. If you're being admitted into a healthcare environment, you may well find that the team will routinely discuss it with you. If you've discussed it with a healthcare team and you really want to keep that going when you've left that healthcare environment, make sure you take a copy, or you need to have the original. The copy is left in your note, so you need to have the original with you. And because if you don't have that, what happens is that a team attending will assume that you are for all active appropriate treatment and will do so. You should keep it where it's obvious. And of course ensure that your next of kin are aware of it. Make sure your GP knows. If you have any regular medical team input, make sure that the medical team know if that you've had it done, if you had it done in a different healthcare environment. And if you change your mind, you can just stop or throw it away, or better cross it through and perhaps write the reasons you changed. You discuss that with your healthcare provider and ask them to cancel it, because if it's been started for a reason other than your request, they may well want to discuss that further. Next slide. I'm nearly there, I promise. So why are they controversial? And certainly they do hit the headlines quite a lot. And I think the reason they hit the headlines usually in this kind of negative light is because they can be applied, or they have been applied in the past in a blanket way across a group of patients without clear discussion with the patients and their next of kin about what actually resuscitation means, and the practical and the realistic outcomes of treatment for patients who might have it. I think it's a really important way, speaking as somebody who fills them in with families a lot, it's really important with patients and families. It's a really important way of establishing what the patient thinks about their own health and their disease process, and a well documented and a well discussed TEP discussion is enormously helpful in facilitating a really good death for the patient, whatever that means to the individual patient and their family. So kind of in summary, I've just put a statement for what each of them are. So final slide, which should say a summary. So an ADRT, or an advanced decision, is a legally binding record which you make yourself, detailing what treatments, including life-sustaining treatments, you wish to refuse if you lose capacity to make such decisions for yourself. And a treatment escalation plan, or TEP, is a plan of care that you and your healthcare team make regarding your preferences and options for medical care in the event that you become more unwell. Thank you. I've got my details on the final slide, so if you can just go to the final slide, that's my email address, and you're very welcome to contact me. I'm not an expert, but it's quite interesting to think about. Thank you.
Wow, thank you so much. That's phenomenal. Such a lot of information and lots of comments in the chat, which I'm not going to have time to go all the way through, so we will answer some of these, and people, as you said, can get in touch with you. So Jehovah's Witnesses hold their advanced declarations in their medical notes is an understanding. This has come from Abigail. How accessible is this to emergency teams in A&E, for example? Also, just if the individual has capacity, they would sign the TEP, wouldn't they? So that's a question. Obviously, we've already said that people will get a copy of all the presentations to everybody. So if there is further questions from this, obviously, please get in touch with Sarah directly. Sue has put, having had someone who had a TEP, if the DNR hadn't been shown to the paramedic, they would have had to have done the CPR. This, I find, goes against the person's wishes, so should be marked on all medical notes wherever they are held. Advocates, which is something I was going to also mention, if somebody lacks capacity or has no family and friends, so much chat happening, I'm just kind of going along, so just bear with me for a moment. Obviously a difficult decision for the patient and the family. I'm aware of patients who have felt under pressure to accept DNR, so managing that message is essential. If they have no,
isn't it?
Sorry.
Because actually, you're saying that's about giving the family and the patient accurate information about actually the likelihood, the pros and cons of having CPR in those kind of situations, or, you know, and the fact that the TEP form is not just about CPR, it's about lots of other things as well.
Yeah, thank you. So Sarah, just wanted to quickly finish, and I'm glad you brought up the media at the end. It's just really interesting. There's a couple of medical programs on the TV at the moment, of which the whole CPR process is actually kind of it gives an image that it saves a lot of patients. And I wondered if you think that messaging that goes out from the media is actually something that then causes an issue in real life, because there's a perception that it's actually going to save a large number of people.
And the link, if you, when you get the slides, the link to that paper is really interesting, because it says that most people's ideas come from the media, and it makes really great TV if somebody has kind of resuscitation and they sit up and ask for a cup of tea afterwards, but actually that rarely happens in real life. And as I say, it's such a small percentage of people who benefit from it. I think that's the message we should be getting out, and the sensational headlines kind of obscure what's actually going on, and actually it should be part of a discussion, not just a, you know, do it or don't do it. It should be part of a discussion with the patient as far as possible. Well,
thank you so much. It's such an informative session, and thank you for getting through so much in such a short space of time. I have a cup of tea now, and I'm sure you're going to be getting lots of questions, so thank you so much for that. So now we're going to be going on to talk about lasting power of attorney and mental capacity with Karen Jackson. Karen works for Enable Law and is an associate for the Mental Capacity Health and Welfare team, providing specialist advice and support to individuals and public bodies. Karen's also an experienced advocate in court proceedings and frequently instructed by the official solicitor and advocates to act for individuals who lack capacity. So really looking forward to listening to your presentation, Karen. Over to you.
Yes, thank you. I'll reflect what said previously is how to do justice to this subject that absorbs much of my life currently and much energy in such a short time. But I'll try my best, and I'm not making any excuses for going back to basics on this. Really, for those that think this is a little bit too simplistic, because even where you have incredibly complex questions in the Court of Protection about capacity and decisions, then the basics are usually what the court starts off with. So really, to emphasize that actually, when you're looking at capacity, you're not looking about whether or not somebody has capacity or doesn't have capacity per se. You're looking at whether or not they have capacity to make a particular decision. And we could go back to the last slide, the second slide. That's lovely. The next one back. That's lovely. Thank you. The piece of legislation that sort of governs these knotty questions, which I can see are particularly relevant for a lot of
sound on here.
Hello. Is that there? Has everybody got the slide? It's headed Mental Capacity Act. Yeah. So the questions that were arising as a result of the previous sort of presentation are particularly relevant to this these issues here, and I know that that a lot of people have talked about capacity. So there are the particular piece of legislation that governs all of this, and is the Mental Capacity Act. And it actually is very clear that it actually is a legal framework for making decisions on behalf of adults who lack capacity to make the particular decisions themselves. And I'm emphasising that again, because every person's life story, their cultural views, their values, their decisions are very, very different. And somebody may well have capacity to make a decision about one thing, but not another. So there are 5 key principles that are running through the law that relates to this area, and these are all relevant to planning and advanced thinking in terms of capacity decision making. So the first is the presumption of capacity. It's a clear presumption that people have capacity. That's the starting point. However, that's not your get out of jail free card, because if you as a clinician or an observer think that someone may not have capacity in relation to a particular decision, then it's incumbent to explore whether they do have capacity to make that decision. The second principle is that every person, whether they have capacity or not, needs support to make a decision. And again, there's a whole raft of case law and regulations and pieces of legislation that sit behind how that support can be made so that it's very person specific. It's a fundamental right of us all to make unwise decisions. And I think you've probably heard on many, many occasions that we all, particularly on a daily basis, make unwise decisions. But it's a particularly sensitive area where there's a question mark about people's capacity, because there is an imperative on behalf of many to actually be overly protective. And there's a particular case law that emphasises this, that what's the point of being in a golden cage if it makes you unhappy. So the right to make unwise decision is a particularly difficult area when you're looking at incapacitous decisions, and that's particularly difficult when you're looking at end of life and particular decisions, where you should live, what you should do, how you should do that when you're very unwell. The other principle is that in any decision, whatever it is, however small and however complex, made on behalf of someone who lacks capacity, has to be made in their best interests. And that's not just a general thing, it's a specific legal concept. And the last principle is that whatever you think, and it goes back to the golden cage concept, is that whatever you do, it has to be the least restrictive principle. So moving on to the next slide, just to give you a very, very brief overview of what some of the sort of references are, is explaining, you know, how these particular bodies fit into the whole area of capacity and decision making. So what we have is we have a very specialist court called the Court of Protection. It's packed full of extreme experienced High Court judges, and even goes up to the High Court. It also extends capacity issues into the Court of Appeal and the Supreme Court. But it actually, what its role is that it is a higher decision-making body. It's a decision maker when no other people can agree on a decision in relation to any contentious property and affairs or health and welfare matters. And it specific remit, and it can't deal with anyone beyond that specific remit, is in relation to people who lack capacity to make the specific decisions. You'll hear reference to OPG. Now, OPG is particularly relevant when you're talking about lasting powers of attorney. And the OPG is actually the government body who act as a regulation authority for deputies, attorneys, and guardians. And these are simply tools to enable others to be able to make decisions on people's behalf. I've had a question about why does it take 12 weeks for a power of attorney to be registered? Simply, I don't know. The backlog, the process, it is an arduous process. But what I would say is that whilst those powers of attorney are being registered, and if someone does lose capacity in that time, then decisions still can be made on their behalf. So they're simply tools, and actually the Mental Capacity Act is very clear that it's both proportionate and actually is person specific. So decisions can be made for somebody who lacks capacity by others pre the registration of a power of attorney, if someone loses capacity in that time, provided the best interest process is followed. And there are particular caveats within the Mental Capacity Act that actually allow for people to make decisions without any kind of redress, provided the proper process is followed. So the other issues that might arise is there might be reference to court-appointed deputies. Now, court-appointed deputies are specific people who can be appointed. They might be professionals like lawyers, or they may well be family members who are appointed by the court to manage the affairs of a person who has become incapacitated, i.e. hasn't actually executed a lasting power of attorney before they become incapacitated. And there are two very distinct types. One, property and affairs, which allows that deputy to manage people's property and their finances and make decisions in relation to those, and one in relation to health and welfare. Now, health and welfare deputies are particularly not rare beasts, they're becoming increasingly less rare, but they're unusual because the presumption of the court of the Mental Capacity Act is that they're not necessarily needed. The Act provides for a decision-making process without the necessity for a deputy. Lasting powers of attorney, again, all they are is allow people to make decisions on behalf of somebody who becomes incapacitated, but it does require the person to be capacitated in relation to executing the lasting power of attorney. So they could be incapacitated in relation to something else, but have sufficient capacity to execute a lasting power of attorney. And again, there are two separate types, one in relation to property and affairs and one in relation to health and welfare, and they're very distinct. Property affairs allows you to manage somebody's finances. Health and welfare allows you to make decisions on behalf of someone in relation to where you live. It may well be what treatment you receive. It may well be, or any number of lower level or more complex issues. What it doesn't do is allow a free rein, because anyone who's making decisions on behalf of an incapacitated adult has to follow a best interest process. And indeed, if someone actually disputes what they're doing, so P, who's the subject of that decision making, or others dispute that, it may well end up in the court of protection. So to make that ultimate decision. So next slide. Sorry, I'm really conscious how much I've got to get through really. Big reminder, so what is the test for capacity? And this will be particularly relevant when these questions are arising. That the test for capacity is that a person lacks capacity in relation to a matter of material time, and so it's time specific, and people's capacity can fluctuate. He's unable to make a decision for himself in relation to the specific matter, and this is very important, because of an impairment or a disturbance in the functioning of the mind or brain. So there's two parts to it. There's the diagnostic test, i.e. someone has an impairment or disturbance in the functioning of the mind or brain. And that doesn't have to be a formal test, but it has to actually meet that requirement. And it flows from that. The reason why someone cannot make a decision is because of that disturbance or functioning in the mind or brain. So, so the next slide, please. So then what does it mean to be unable to make a decision? What the law says, and this belies a raft of case law and a raft of process, but that P is unable to make a decision for himself. He's unable to understand the information relevant to the decision, so that the relevant information will be very different depending on the decision, or retain that information, or, and this is really where often people are found to lack capacity, is to use or weigh that information as part of the process of decision making, and also to communicate that decision. And it presupposes that all efforts have to be made to try and actually engage P to see whether or not they can communicate. And again, references that capacity decisions are decision specific and time specific. So if you contextualize that with the two speakers that have gone before, these are all really important things to understand when you're actually discussing with the patient what a decision they're wanting to make about their care planning, about their advanced decision making, and so forth, because the more information that you have about people's wishes and feelings, the better. And the more planning you have, and the more information you have about the rationale of them actually not understanding information and not being able to make that decision, the better. So next slide. Yeah, what are best interest decisions? This is really, really, really important. And again, it goes back to who is the person, who is the decision maker, who is making the best interest decision? Well, it may be the hospital who's deciding whether or not to actually sort of recommend certain treatment or withdrawal of treatment, or it may be the attorneys, or it may be a social worker. There's no specific criteria as to what priority is in place as to who's the decision maker. It is the person who is making that decision on behalf of P. So there's not necessarily a priority, but where you have a deputy or attorney in place, there's a reference to them actually having a higher level of priority in terms of where did their decision come in the scheme of things, but bearing in mind that they have to follow the best interest test. So the purpose of the best interest test is not to substitute your own opinion. Absolutely not. It's actually to filter that process through a best interest process. And there's a very, very general checklist that's actually in the legislation, which gives some guidance. But key to this, and probably the most important things is that actually do not judge people by their cover just because they are presenting in a particular way, and it goes to people's values, wishes, beliefs, their fundamental system, and also what that person's wishes, feelings, beliefs and values are. And again, the relevance and importance of gathering as much of that information, in particular if you're encouraging people to execute a lasting power of attorney, the better, because the court is stuffed full of case law where lawyers and judges try to disentangle from information that's gathered together about what those wishes and feelings would have been should somebody have should somebody be capacitous, have been capacitous and been making that decision. So the next slide. So I'm really rushing, I'm sorry about this. So talking about lasting powers of attorney, what are they? Well, they are actually, they are a document that actually indicates that you want a particular individual or individuals to actually be able to make decisions on your behalf should you lose the capacity to make those particular decisions. What I would say is that I personally have executed powers of attorney, and I've encouraged my family to do that, and I would encourage everybody to do it because I think they are incredibly useful guides and to what somebody wants. The most important person as to what they want and what their wishes and feelings are P, but often you'll find that the next best person are the family. This doesn't necessarily mean they have the overriding decisions, but they don't automatically have that right to say so simply because they're family. Once somebody reaches 18, and this is a discussion that I frequently have with parents of disabled children, is that they have no more right to make decisions on behalf of an adult than anyone else. They don't have any priority. So it's a really good forum for actually identifying who you trust and want to make decisions on your behalf, and also to indicate, in particular in relation to health and welfare matters, what types of decisions you'd like them to be able to make and what your wishes and feelings are. You don't need a lawyer. You really, really don't. It is a really relatively simple application, which my view, is actually made slightly more difficult by the fact that there are blow-by-blow instructions on the website of how to do it, which I think probably might make people think it's more complicated than it is. There's a sort of question mark about that people change their minds. Yes, of course they can change their minds, and certainly the people can withdraw their decision about who's their power of attorney at any time, and certainly the forms allow for you to decide in advance whether you want a primary power of attorney or you want joint attorneys who make decisions together or separately or individually, or a substitute attorney. So there's all sorts of options. So the cost is I think it's £82, but it's a separate cost for if you apply for a property and affairs and health and welfare, and they are distinct. And I think it's a really, really important point that people don't always know. Frequently, you'll have powers of attorney executed on behalf of people for property and affairs, because it's pretty critical to have that. When somebody loses capacity to manage their finances, then frequently there are real issues about that. But more importantly, and knotty, is the importance of having a health and welfare attorney if you really want these issues to be dealt with on your behalf by people that you trust. So you decide upon who your attorneys are. Usually people have family, not necessarily. There's no specific requirements, and you make the decisions in advance. And it's really, again, really, really well set out in the sort of informative documents that go along beside about how you do that. You can actually make very specific requests about things. Critical to this is the person has a capacity to execute this document. And sometimes they're made very late in the day, where people are clearly starting to lose capacity. For making a power of attorney, though, it's a relatively low test. It's the same test as I've gone through previously, but the relevant information is really understanding what a power of attorney is and what it would cover. So don't delay, but you cannot have execute a power of attorney when you've lost capacity to be able to do that. And there will be a requirement for a third party to sign a certificate confirming that the person who is executing that power of attorney, i.e. asking for a power of attorney, is capacitist. So there are exemptions to the fee that apply. So I think if people are on a low income or others, I have to say I'm not particularly skilled on knowing whether or not there are complete exemptions, but certainly there are exemptions to that fee. So the next slide. So what next? Financial LPA, once it's executed, and I do agree, it isn't a quick process. Sometimes they take quite a long time for the OPG to come back. They always come back to the people who are being asked to be powers of attorney to say, do you still agree to this? So it's quite a slow process, but as soon as it is registered for finances, the attorneys can start immediately if they want to. If everyone's agreed they can act for you, you can, even if you still have mental capacity. A health and welfare attorney, however, can only be used when P lacks capacity. So yes, it says you get a letter when you're appointed, and you can say whether you still agree or not agree. So I mean, a person can't be forced to be an attorney; they have to agree to it. So the position for those who've never had capacity is that you cannot have a lasting power of attorney. So the decisions can only be made if there are by others through the best interest process. So you don't have to have a power of attorney to make a best interest decision. However, the more complex and more detailed, particularly where we're talking about medical intervention, the more likely that that decision may well have to be referred to a court, which is where I come in and spend a large part of my life. So so that's the next slide, I think. So really, this is the final slide. And as I said, it's a very whistle-stop talk because I was given 10 minutes to do this. So, and I do hope it's not too superficial and people aren't feeling left out, very frustrated with lots of questions, because I'm certainly around to answer anything that people want to ask afterwards. But the benefits of an LPA, obvious, really. It's clarity over the decision maker, and that's frequently an issue. So who are the decision makers? And there's conflict over, is it the local authority? Is it the healthcare trust? Is it the family? Who is making the decision? And that frequently leads to conflict, and frequently then leads to really difficult decisions, a lot of bad feeling, a lot of misunderstanding, and often ending up in court that may well not end up in costing a lot of money for people. It means that decisions can be lawfully made on your behalf. As I said, you can still make lawful best interest decisions in relation to non-capacitous adults through the best interest process. However, it does clarify your role as a primary decision maker in that area. What I would advise is if anybody is making a decision in their best interests on behalf of someone, show your workings out. Show why you have made that decision and why you've come to the conclusion that a particular decision is in that person's best interests. Because if there is any dispute, then that will be very important information. So again, absence of LPAs can result in very expensive applications to the Court of Protection. There's very little legal funding through legal aid for this area. Having said that, there is legal aid, but it's usually means tested. So where P has assets, then you really don't want them to be used. And it's, for me, although people might have particular views about lawyers, it's particularly heartbreaking for me to see people's life savings being used in contentious court of protection proceedings on their behalf. So I don't know whether that actually helps anyone in the context of what we're talking about. And again, apologise for the whistle-stop overview that has really touched upon a really contentious and difficult area.
Thank you so much, Karen, and so much important information and lots of comments in the chat. We are just conscious of time, so what I'm going to do, if that's okay, thank you for your kind offer. We'll pick up all of the comments and questions and just put those to you separately from this session. And you know, just kind of to say, having supported lots of people without capacity through these processes. And also just from a corporate and working as an independent visitor, you do see how important having all of these things in place and being done in the right way is just so important, isn't it?
Absolutely, absolutely. And I think people do really need to remember that they are making decisions on behalf of people and follow those principles, and that really will assist in any process that you're concerned about.
Yeah, thank you so much. Lolly and I were just talking, saying we're going to have you back for a much longer session because I think we could do a whole afternoon just with you.
Yeah,
so.
I felt quite stressed about it, so I have to say, in terms of how short it was.
Yeah, but it affects all of us at some point in some way, whether that's with a relative or whether it's on a personal level. So really, really important information. Thank you so much.
Thank you. Bye.
Thank you. So now we're going to talk about advanced care planning. And that's going to be with Siobhan Norris. Siobhan is an advanced nurse practitioner for Cornwall Hospice Care with over 20 years experience as a community clinical nurse specialist in palliative care. I'm really looking forward to hearing your presentation, Siobhan, so over to you.
Thank you. Afternoon, everyone. Just waiting for my, thank you. So yes, advanced care planning. So Lolly asked me to talk about advanced care planning in 10 minutes, which to a palliative care old school nurse like myself is a little bit like an oxymoron, but I'm going to do my best and try and break it down to make it feel a little less overwhelming. So next slide, please. Next slide.
Sorry, bear with me. It's not moving on at the moment. I'll try again.
That's okay. It's great for my nerves.
Always fun when that happens.
Don't worry.
Yeah, no, sorry. It seems to have frozen on me. I'm not having any joy this end.
Okay.
We'll catch up, Siobhan, if you just want to.
What I might try and do, if you can give me some verbal guidance, is if I open the presentation myself.
It's working. There we go. We're off.
Oh, is it?
So can everyone see that next slide now?
Oh,
yeah,
thank you ever so much. Okay, so talking about progression of disease or dying is hard, and it's hard for everybody. Obviously for patients and those that care for them, but also for health professionals. And I think as a palliative care nurse, if I had been asked one question more than any other, it was about teaching or support with difficult conversations. And that's a phrase that is often coined in healthcare. What I tend to reflect back is maybe that it's not a difficult conversation, but actually an important conversation, which is why maybe it does always feel hard, because it is just important. Advanced care planning helps to enable this conversation. It facilitates the conversation, it supports it, maybe gives it a little bit of structure and a bit of a roadmap, which is perhaps when something this important is what we need. Next slide. talking allows us to establish an individual's wishes with regards to the delivery of their care, which is a huge statement. And as you can tell by all of the speakers that have already spoken this afternoon, some of the wishes with regards to care are quite formalised and quite specific. An advanced care plan allows a more personal aspect to the delivery of your care to be discussed. That this might be where you want your care to be based, where you want your end of life care to be, as well as the ceiling of care, so the things that Sarah spoke about with the treatment escalation plan and resuscitation. But an advanced care plan allows you to talk about some of the personal aspects, so who is important to have around you at that time, whether that's family or what family means to you, whether that's friends. But it can also mean some really personal things, for example, little things that maybe aren't easy to mention in other more formal conversations, like not wanting to be seen without your teeth, or the really importance of always having your makeup on. I know I did an ACP for a lady in Gloucestershire who had MND, was one of the most glamorous patients I've ever met, and her not having her lipstick was really important. And that was something that she felt we might think is not important, but it was actually fundamental to her feeling supported at that time and heard. So when you've had these conversations, advanced care planning also allows us to record these wishes and to communicate them. I'm going to come back to that because these conversations are important, and recording and communicating them is just the very essence of what an advanced care plan is. Next slide. So Lolly also guided me that the audience today is quite vast. So I know we have extremely experienced professionals, but we also have people living with disease, and we also have carers. So what I'm going to try and do is look at advanced care planning from all three of those groups. But the thing to always remember, whatever capacity you're watching this afternoon, is that advanced care planning is a process. It is not one conversation. It is accumulation of conversations over times, that they are documented and that they are reviewed. And that's the kind of key message I would say about an advanced care planning. Next slide, please. So if you're a health professional and you're looking to do an advanced care plan with a patient, the most important thing to remember is that it is a patient-centered document. It's about the personal preferent wishes of the patient. So one of the things that I would say is your communication probably needs to be slightly different than in some of the conversations that we have. For example, if you've started a medication to manage a symptom, we might ask quite specific questions of that person to see whether it's been effective. One of the things that I try and do when I'm doing an ACP is to try to only use open questions, be quite reflective, and to listen and to do less of the talking. So one of the ways that I find is best to do that is to make sure that you go with a very evidence-based approach. So I will do and gather as much information as I possibly can about my patient. So that means it might be diagnosis, date, treatment, if they've got METs, where are they? If they've got heart failure, what's their ejection fraction? If they've got renal failure, what's their EGFR? All of that medical jargon, I will try and absorb as much as I can. I will also see if I can find out if there's any reference to their mental capacity, whether they've got a TEP, whether they've got any lasting power of attorney. I will just hoard as much information as I can about that patient. See if there's any documentation about their rate of change. Absolutely anything that you can find out about that patient, I will try and find out. So that when I go into that conversation, I know where that patient is clinically. I also, when I do ACPs, try and make sure that I know as much information about what services, what treatments, what the community around that patient can offer that patient, so that I know what I can utilise to support that patient and to respect their wishes and enable their wishes. And then there's the conversation itself, which I think is a study day, or if not a conference in itself, because it's about difficult conversations or important conversations, and it's about starting them, which I think as professionals is often something that we find exceptionally difficult. So when you have all that information and you're in front of your patient, it's about starting the conversation. And sometimes that's as simple as asking a patient what they understand about their disease, how has it affected them, and also just to try and find out prognostically what they think, if they've noticed that they've changed, if they've noticed that they're becoming frailer. I often ask who they talk to, who's their favourite GP, who do they look forward to seeing at the hospital, because it's not just who they're under, it's who that they find helpful. And obviously these kind of conversations do enable conversations about ceiling of care and DNR, but also those things will often come up as well. And then ultimately it's about establishing people's preferred place of care, which is a phrase that we use a great deal, but it's where that person wants that care to be centred. And I've put on the other side "and review" because these conversations should happen continuously. They should evolve through different stages of disease. Always, once this conversation is never done, once you've done it, it's always there to be done again. Next slide, please. So then we come on to carers, which is again one of my favourite subjects in the world, and it's maybe what a carer is. So to myself and many professionals, I think carers come in many forms. Carers are who supports that person, that patient, and that can be family, it can be friends, it can be whatever it will be whatever that patient says. And those people are often very instrumental in the care of patients and understanding what's important to them, which is what the advanced care plan is about. And sometimes it is as simple as the person who has the most therapeutic relationship with the patient. So sometimes, certainly as a hardened community nurse, care providers who provide daily care to patients that often live on their own, or they have an immense amount of knowledge about that patient on a very personal level. And so often it's the people that are wrapped around that patient on a daily basis that will often come across the questions or be asked the questions by the patient. And then the most important thing then is to escalate that. Next slide. For the patient, so an advanced care plan is about your wishes, and it's the more personal side of your wishes, what's important to you, what matters to you. And sometimes, just as it's hard maybe for a professional to start a conversation, sometimes for a patient it can also be hard to start a conversation about something so personal, especially when there's so many huge conversations going on around them. And what I would say is, the thing that probably is best to start with is the thing that you're ruminating about, the things that maybe you're a little fearful of and have questions about. So that could be about treatment options, or it could be about medication or care, or it could be something slightly larger, for example, what is going to happen to me, how are things going to be? But whatever it is, the most important thing is to ask, and who you ask doesn't matter. And what I would say is you'll probably know who to ask. You'll probably have that one person that you can talk to, whether that's a professional, whether it's a CNS, an outpatient, or whether it's the person that pops in with the newspaper every day. But just ask that question, and that person then can initiate the process. Next slide. So as Dr. Gibbons said, the most important thing is to record, share and communicate. So when you have these really personal and incredibly important conversations that complement all the formal documents that my colleagues have spoken about already, the most important thing is that they are written down so that that person and that family know that those wishes have been heard, will be respected, and we will enable them as much as possible. Now, this document here is the document that is used here in Cornwall, and there are documents throughout the country. I've used many documents in the counties that I've worked, and it is a document that you can access through your GP, district nurses, community palliative care nurse, community matron, and you can document your wishes on this. The thing, however, that is really important is this document is shared, because if people don't know that you have this document, if people don't have a copy of this document, then those wishes and preferences cannot be supported. when I do these kind of pieces of work with people, I will ask them who they want to have this document. And that will probably be their family and their nearest carers. I always make sure they have a copy of the document in the house. And I will also suggest things. So I will make sure that the GP has a copy, the district nurses have a copy, site-specific nurses have a copy. Because if it's not shared, if it's not known about, it's not communicated, then unfortunately all those invaluable patient-centered conversations and most importantly wishes don't actually follow through. Next slide. Thank you. So I'm sure with all the formal documents that my colleagues have discussed, and certainly with advanced care planning, which is a slightly more personal document, communication is absolutely key. And I think that in palliative care, it's often a thing that we're asked to teach or to help people with on a regular basis. I think a few things I would say, because it really is the fundamental to all of these documents and all of these assessments and conversations, is as a professional, if someone asks you a question that does feel hard or is quite huge, then know that they trust you enough to ask it. You do not need to know the answers. It's the fact that it's been asked. If you ask that question, even if you don't know how to answer it, acknowledge that you heard it and that you will get the person that can answer it. And that is all as simple as is needed. If you're a patient and or a carer, absolutely a carer, if you have a question or you have a fear, it doesn't really matter who you ask. But what I would say is ask the person who you think hears you. So if there's that GP that you always hope is on duty when you phone for an appointment, that is probably the person you need to speak to, if it's something as personal as a wish and a preference. I haven't, unlike my colleagues, been as helpful as putting my email at the bottom of my presentation, but I will put it in the chat. And if there's any questions or anything, I will, of course, answer them. Thank you.
Thank you so much, Yvonne. Again, amazing information, and we really, really appreciate the presentation. Unfortunately, because we're running so close to time and we've got a couple more speakers, if you don't mind putting your email address in the chat, that would be amazing, and we can pick up all of the comments and chats. Things that might also just kind of inform some more answers and send that across to you. Is that okay?
Yeah, of course it is.
Wonderful.
Yes, anything I can do. Thanks.
Thank you ever so much. And thank you so much, Adrian, for bearing with us. It's so much interesting information today that it's hard to know where to cut things short, because I think there's so many important things to get out there in terms of Dying Matters Week. So Adrian is the estate planning consultant, member of the charity team at McClure. He advises clients on estate planning and ensuring clients plan for later life and protect their hard-earned assets for future generations. Over to you, Adrian.
Thank you very much. Hopefully you can hear me okay. My name is Adrian Howlett. I work for Jones White Solicitors, and as I've just been introduced, I will talk to you today about wills and probate and give you hopefully a wee understanding of what it's all about. So I'll kick straight in, no messing about today. First thing I'm going to talk about is wills. If I was in the room with you now, I would be saying, right guys, let's have a few hands up. Let's find out who's got wills and who hasn't got wills. It's a very important document to have. I suspect there'll be lots of nervous people not prepared to put their hands up. Oh, I've got the hand up, so that's good. Someone has got their will done. Well done, you. It's something that everyone knows about. It's strange. A will is not something you need to explain to someone. They know what a will is. It's got something to do possibly with money coming your way, and that's why people know what a will is. And it's very important that we all should have a will, especially everyone attending today. I suspect there'll be a trigger point in your life to determine when that will happen. Usually it's when something happens, someone that's close to you dies, or maybe you have a situation that you're aware of in your life, and it triggers you to do that. So you will reach that trigger point at some point, but please consider it. I'll just talk to you very briefly about what needs to go into the will. The first thing If you're meeting me, I'm basically going to get to know you. I'm going to get to know about your family and your situation. And from that, I will then determine what the will should say. The first part I would agree on is your executor. Usually that's someone close to you. I'll use myself as an example today, so I'll relate to myself for the examples I'm giving. So I'm going to appoint my wife as my executor. I have 3 children, so I would have my most organised child, not necessarily the oldest child, by the way, the most organised child as the reserve executor. And we'd always recommend try and keep it simple, to try and keep it down to 1 or 2 people rather than have lots of people involved, because that just involves lots of people signing papers at the end. The second point we would cover is your beneficiaries. Who's going to benefit from your estate? Your estate is your assets, and your assets are your property, savings, bank accounts, and everything else that you own in the world. So again, in my situation, I'm a married man, so I'm leaving everything to my wife, whom failing to my 3 children. Obviously, there's not everyone have got wives and husbands and children, so you might be leaving it to your nieces and nephews, friends, etc. I will also cover other areas that we established when I was talking to you earlier. So you might need guardians for your children if you have children underage. You might be in a property that you own and someone else lives with you. It could be your spouse, it could be your partner, it could be someone else, and you want them to live after you in that house after you. So we would do a right to occupy in that situation. I do get asked what happens if I don't have a will. Best thing to do is get a will, and then you don't have that problem. But if that is the case, effectively you do not know where your estate will go. The laws of intestacy take over, and they will determine where your estate goes. In most cases, it will go where you want it to go, but not always. And it will take longer and cost more if you die intestate to get the estate wound up. It does leave a wee bit of a headache. I attend shows regularly, and I have a conversation with people, and then the ones that say to me, "It's all right, Adrian, thanks very much for your time, but I'm not going to do my will today. That means I'm going to die." Not quite correct. I'm still here. I wrote my will a long time ago, and I'm still alive. I just finish off with a wee bit of fun. I say, well, do me a favour. Here's a pen and a pad. Just write your name and number on there, and then just write your date of death for me. And they look at you, and then the trigger goes, and they go, you've got a good point there, Adrian. Thanks very much. Let me take that leaflet from you. So we don't know when it's going to happen, so let's plan for it and avoid that problem. Why would you want to come to Jones Wright solicitors? Well, you don't need to. You can use any solicitor you wish. Obviously, lots of people attending today will have family solicitors, so by all means use them and get your will sorted. We've been preparing wills since 1853. You'll be pleased to hear that I've not been around since 1853, but that's how long we've been writing wills. And we effectively think there are 3 stages to writing a will. You'll see on the slide there, just missed that. We encourage people to make will as 70% of the population do not have a will. I think I might have mentioned that earlier in the presentation. So 30% will, 70% won't. The 70%, if that's you, by the way, you're just normal. That's fine. The 30% are the ones that are just slightly more organised. But we have 3 steps in making a will. The first is who would get your estate when you die. We've talked about that already, so I don't need to repeat that. And every will writer and a solicitor in the UK will do that. We're no different than any other solicitor for that purpose. But what we do is we think about what effect that will have on your beneficiaries and where your estate will likely to go next. So to put that into perspective, I'm very quickly going to tell you a story, because I think stories get remembered. No, you can go back one. The story is a client of ours that came to us to sort out their probate, which I'm going to talk about in a minute, for her father. She was in her 70s, Dad was in his 100s when he died. No problem, we'll get that sorted for you. We got all the papers together, and we established that the estate that he was going to pass to her was going to cause her a problem in the future with inheritance tax. So what we did is did a deed of variation, which can be done up to 2 years after death, where we can amend the will and put his assets into trust. So that's what we did. So if you look at point number 2, what effect will that have on your beneficiaries? If Dad had come to see us, we would have spotted that straight away, and we would have said, listen, you're leaving a problem for your daughter. Let's set up a trust now during your lifetime. We did it after death, but you can do it before death. And where is your estate likely to go next? In this particular case, if we hadn't have given that advice and hadn't sorted that, £55,000 would have gone to the Chancellor, to the taxman, when the daughter died. I won't tell you the full story because she actually died a few years after him, but we were able to save that money and save the family £55,000. Next slide, please. How can you use Jones White, or why would you use Jones White? Well, we have currently have a free will scheme that we run with Cornwall Hospice Care. All we ask is you consider a donation for a charity of your choice. Needless to say, we would hopefully expect you to choose Cornwall Hospice Care for your donation. We generate hundreds of appointments per month, and the reason we do it is because about half the people that come to see us then take up a paid-for service. You heard Karen talking earlier about power of attorney. A lot of people take power of attorney, other people take trusts. This is very successful, and we generate an awful lot of money for our charity partners. Last year, in what was a terrible year, we still managed to raise 240,000 for our charity partners and 38 million in gifts and wills. In the last 5 years, that figure is 200 million, the money we have raised in conjunction with our clients for charity. Next slide, please. I'm going to quickly mention gifts and will because I just mentioned that in the last slide, especially as we're working with a hospice today. Effectively, it's an amount of money you leave to a charity or a good cause. It's one of 3 items. It could be a pecuniary, residual, or specific legacy. Pecuniary is money. It's £100 or £1,000 or something like that. You specify the amount of money. Residual is a percentage part. So you would say, let's say, leave 99% to your family and 1% to the hospice. And specific would be, we had a recent client that left a car to a charity. So it's something specific. Remember, the gift can be as little or as much as you want. We have clients that leave their whole estate to charity. Some people just leave a small amount of money. It's all very, very worthwhile. And you can change your mind at any time. We just write a new will for you when you want to do that. We call that a getting on with will. Let's get the will done today, and then if you want to change your mind in the future, that's absolutely fine. You never pay it. That's the biggest part of a gift and will. You'll never see that money actually leave your bank account because, yes, you guessed it, you've already died. So it will be your executor that pays the gift and will out to the good cause. So please consider one last legacy in your gift, in your will, as a gift and will, and I think the hospice are a very good cause for that. Next slide, please. Very quickly, because I know I'm trying to keep time up for the next person. There will be 30% of you that already have a will in place, so well done you. We do recommend that you review your will on a regular basis throughout your lifetime. It could be for a change in circumstances. You might have had a brother or sister as executor, and now your children are old enough, so you want to put them on. We might find an error. Once upon a time, many years ago, I had a client who had a will for over 20 years. Well, they thought they did anyway. When I checked it, it actually never been signed or witnessed. So that's not a will. And going back to the story I spoke about earlier, is your will enough? You'll only know by talking to us. We can then check for you to see whether a will is enough or whether you should have something else. Remember, it's a bit of an obvious statement, but it's very relevant. You can't change the will after you die. So it's well worthwhile checking that will before that event happens. Next slide, please. I'm very quickly going to fly over this slide, although it's a very, very important slide. A will is a wish of where you want your assets to go. It doesn't protect your assets. So we would check your circumstances, and we may recommend a trust to work alongside your will to protect your assets. It could be a testamentary trust plan, or known as a will trust, or it could be a family protection trust, known as a lifetime discretionary trust. Effectively, trustees will look after your assets after you die and make sure they go to the right places. I can give more details on that on specific circumstances if you make contact with me. Next slide, please. So that's the will part of the presentation. I will now move on to probate. You've effectively made your will, you've now died, and unfortunately, this is the process whereby your legal and the legal and financial process starts to deal with property, money, and possessions, as I mentioned earlier, called your assets, or we call it the estate of a person who has died before the next of kin, or in most cases the executor who is named in the will, can sell or distribute any of the deceased assets. You need to apply for probate. This is actually a legal document. It's issued by the court, and this confirms the estate of the deceased. It's point to note here is probate is not required in all cases. So if you have a small estate, as it's known, it is possible to do that without going through the probate process. However, for definite, it is required if you own property. So you have title of a property, or a share of a title of property, or properties. And where liquid assets are concerned, i.e. bank accounts, etc., it will be down to the financial institution. They will determine, based on their limits, their thresholds, whether a probate would be required or not. If you use a probate practitioner, they would know these limits and be able to advise you. And I've given 2 examples on the slide there. Post Office release more than 10,000, whereas Halifax will release anything up to 50,000. Next slide, please. The application for probate requires to be made by the executor of the will or an agent of, i.e. a solicitor, and depending on the value of the estate, the deceased estate, this will determine what the executor has to do next. If the estate is over £325,000, this is the lifetime allowance that we all have in this room today. We each have a lifetime allowance of £325,000. If you're married, you get the uplift of the £325,000, so you get £650,000. And there is another allowance for residence nil rate band, which I don't have time to go into today. If you have children and you own property. But effectively, the probate application must go to HMRC in this instance if you're over the 325 or 650, and they will confirm what the inheritance tax position is. If it's less than that amount, then the application can go straight to the probate registry. Once probate has been granted, this obviously, the document you get can be then provided to the executor, and then they can administer the estate and start selling property, closing bank accounts, and then distributing the funds that they gather in to the beneficiaries named in the will. Next slide, please. How long does it take? I had a chat with my probate team yesterday just to confirm what the latest timescales are, because they do change. One thing they did say to me is things have got so much better because they are developing a process now whereby applications are submitted electronically, which makes things much quicker. There are teething problems with that. However, the timescales have been dramatically reduced, which is for the benefit of everyone. The approximate timescales they're recommending at the moment, if the estate's over 325,000, as I mentioned earlier, HMRC are estimating about 3 weeks timescale for processing. They then pass on the papers to the probate registry to confirm, and they are currently taking about 8 weeks to grant probate upon receipt of application and any relevant documentation from HMRC. We caveat here, that is an experience that we have. At the moment, we're probably doing about 4 weeks, but this can dramatically change throughout the year, depending on the season, because it does get busier during the winter, depending on the amount of applications that the probate registry are dealing with. Next slide, please. How much does probate cost? We use a independent auditor at Jones White, so they assess the file and the fee. This ensures that there is a fair fee charged to the family, to the executor. It's very hard in advance to dictate how much that would be. I know that there are certain probate plans you can apply for. As a rough guideline, it usually works out at about 2 to 3% of the estate value. And in terms of outlays, there's £155 payable for the grant of probate, and there's also a £1.50 charge per certificate, and you need a certificate for each asset that needs winding up. Next slide, please. I'm not going to go through this full slide. I think I'm just going to say, guys, don't go down this lane. Just get your will sorted, and then we don't need to worry about this slide at all. Effectively, you just need to get your will sorted. It saves a lot of hassle, not for you, because you've died, by the way, but a lot of hassle for other people. So please get your will sorted. And as you'll see from my last line there, Please don't forget, if you're younger, to make sure that your parents and grandparents have their will sorted too. And that's me done. Next slide is just a wrap up to say, get it sorted. You know, longest journey starts with the first step. For those that haven't done it, there is a free phone number there if you want to give us a call, and there is an email address that I presume will be supplied with the slides. Thank you.
Adrian, thank you so much for literally whizzing through so much important information. I'm hugely conscious of all the things I don't have in place after today's session, so we'll definitely be, I've literally been taking snapshots and sending to my family as you've been talking. So great information, thank you so much. We will share some questions with you. I'm just conscious of time because we've had quite a lot to get through today, so thank you so much for that. And as I've said all along, we will share all of the presentations with you. So I'm going to also say to James, thank you for hanging in there with us, James. James is going to briefly talk to us about digital legacies, and he is the founder of the Digital Legacy Association and My Wishes. And he is researching end-of-life technologies, apps and websites, and also organises the annual Digital Legacy Conference. So over to you, James. Thank you for bearing with us as well.
Yeah, we can't hear you, James.
Hello, is that better?
Perfect.
Amazing. Apologies. So we've heard some wonderful speakers already today talking about the importance of making plans for our future healthcare and the legal aspects. What I'm really going to start to explore and get you to think about today is also our digital life, our digital assets and our digital legacy. So hello, my name is James. I'm the founder of the My Wishes app. My Wishes helps people plan for death in a modern, person-centered way. I founded the Digital Legacy Association at 2015. We launched it at Hospice UK's conference. As part of the Digital Legacy Association's work, we run an annual conference, unimaginatively called the Digital Legacy Conference. And then I also sit on various boards, and I'm also the Digital Research Fellow at Michael Sabel Hospice in North London. So as we all know, the way in which we communicate has now changed, and we're living in a time of digital migration where assets and behaviours that used to live in this physical space is increasingly moving over to the digital side. Now that's whether it's the money that we use, the way in which we shop, the way in which we store photos, even the games that we play. We're living in this time of migration, this time of flux. And it's a messy time because assets are residing in each, and when any migration occurs, there's a mess. Now, I'm going to explain two very quick terms. So the first term is digital legacy. And this term has started to become a bit more well known over the last few years. And according to our research that we run every year called the Digital Death Survey, about 50% of people now have got a fair, an awareness of the term. But ultimately, our digital legacy is what remains of us digitally once we die. And our digital footprint, so the trail of digital information that we leave, can also help to inform our digital legacy. It doesn't become our digital legacy, but it can help inform our digital legacy. Other places that might inform our digital legacy might be a newspaper obituary that's published online. It's not created by us, it's created by someone else, but that can also feed into our digital legacy. On Facebook, our Facebook timeline, although we might create a Facebook account, it's co-curated with other people, with our friends. I might post something, a friend might post something underneath, a family member underneath. So that is co-curated. So our digital legacy, in a similar way to our legacy, has these different assets and different facets to it that feed into it. And our digital legacy is becoming increasingly important for a number of reasons. So on the left-hand side here, this is a screenshot of my housemate from university's Facebook account. Ben died of adult sudden death syndrome a few years ago, and his Facebook account is very important to me. It's important because when we were at university, we took digital photos and they were uploaded to Facebook. So we don't have printed photos, they're digital. They've migrated from the physical to the digital. We've shared messages with one another. So those messages are still within Facebook's ecosystem, so I can see those photos. And we're also able to, on certain dates, people post, for example, on his birthday, they will post messages and share memories. So this part of Ben's digital legacy is important to me. As is a fantasy football league that's been created by a friend of ours, that again, Ben used to play fantasy football before he died. And again, that forms part of his digital legacy, and it's important to me. Now, when we ask the question in the digital death survey, once again, if someone you care about dies, how important is it for you to be able to view their social media accounts? 13% said it was extremely important. Nearly 30% said somewhat important. And then neither important or unimportant is 20%. Now, this is changing all the time, but you could, if you put a line down the middle there, you will see that about 50% of people place a value on someone's digital legacy who's important to them. The second term we're going to look at is digital assets. So just like we've just heard, we have assets in the physical space. We also have digital assets that sit in the digital space. And these are ultimately possessions that are purchased, stored, or available online. So a digital asset might be a photo I've taken on my phone. It might be a Bitcoin that I've purchased and is held in a wallet. It might be a movie that I've downloaded. It can be an array of these different things of both a financial and a sentimental value. And they can be spread across online services, so social media sites, other online platforms, perhaps a cloud storage platform or a video storage platform. Then we've got the physical assets, so where they could be held within. So our digital assets could be within our laptop, it could be on our computer, it could be on our phone, it could be on our old phone, it could be on external hard drives. So we've got an increasingly vast number of assets spread across these different places, often with passwords in front of each, often with passwords that aren't the same as each other. So a couple of things to reflect on. When did you last print a photograph that had you within it? The next thing to reflect on is, do you have a password on your mobile phone? So first of all, I haven't printed a photo of with myself in it for a very, very long time. I don't know, 3, 4, 5 years. Do I have a password on my mobile phone? Yes. So when I was younger, my mum used to have next to the landline phone, we used to call it the phone back then, but now we call it the landline phone. She used to have a pad next to the phone with all of the important phone numbers. And should something have happened to her, I would have been able to access those photos. Now my mum has got her password protected phone as the main place where she stores her address book. If I didn't know the password for her mobile phone, it could cause problems following her death if I had to arrange the funeral. If there was photos and videos on that device, or if there was photos and videos perhaps on her computer, it can cause problems. So we're creating and purchasing many, many assets and dispersing them across multiple places. And it's important that we reflect on these in order for us to be able to make suitable plans for ourselves and our loved ones. So can somebody access your phone book to perhaps at a later date inform your friends and family that you have died and when the funeral was taking place? The second thing is, would someone be able to retrieve photos on your mobile phones? Would they be able to read the messages on your phone? Would you want them to read the messages on your phone? How will the people or persons dealing with your online accounts know which videos and photos that you've created and stored online are of sentimental value, and how would they know which ones they should keep? And how will your favourite photos and videos be shared amongst your friends and family, both online and offline? So just to recap, our physical lives, our physical assets are increasingly moving over to the digital realm. So as mentioned very briefly earlier, the Digital Legacy Association launched in 2015. We take a bottom-up approach to digital assets and digital legacy, where we raise awareness amongst the general public and healthcare professionals. We run training courses, we evoke relevant conversations, and in doing so hope to have improved conversations and better outcomes. And we argue ultimately that digital assets and digital legacy planning should form a holistic approach to advanced care planning. And as mentioned, we do this through as many different means as possible, contributing, screaming and shouting about it, ensuring that it's on the national radar. Now, on the Digital Legacy Association website, there's a For the Public section, which has got step-by-step tutorials and a social media will template. Now, this is a non-legally binding document where you simply state which accounts you've got, what email addresses are assigned to each, what you want to happen to that account, and we go on to talk about the different platforms and what you can do in a minute. If you've downloaded a copy or if you've backed it up anywhere, and to whom you want to assign administrative or admin access to. So this is a free to download. Everything on the Digital Legacy Association site is free, and it's free to download Excel templates, so feel free to download it should it be of interest. We support professionals, so we've got a conversations framework, again on the Digital Legacy Association site, looking at possible places where triggers could be. So if you work in a hospice and you see somebody on their mobile phone and they haven't wanted to engage in conversations about advanced care planning, you might want to ask them what they're doing on their mobile phone. They might say, oh, I'm just looking at some photos of my children. And then you say, oh, okay. And you have a look maybe, and you ask where that photo was taken, and you ask for the context. And then you might mention, so have you shared this photo with such and such? And if they haven't, or if they have, then, you know, it opens up these conversations, and it makes end of life planning be dehumanized, because it's about the assets, it's about ownership, it's about the loss of data, it's about, you know, making sure that these things that are important to you are passed on, rather than it being about the demise of the physical self or the loss of a loved one, or, you know, those other harder to address conversations. So it can be a soft approach to advanced care planning. But yes, there's lots of information there for healthcare professionals. There's also leaflets that you can download, posters. We've got some for Diabetes Awareness Week this week, and we've got lots of other stuff. So I know that I'm speeding through this like a bullet, but and we've got very, very little time. I think I've got about 3 minutes left. So I'm going to finish with my wishes. So my wishes mission is to utilize technology in order to normalize end-of-life planning. So we do this by taking a fully holistic approach. My Wishes is free to use. It enables our community to document their wishes within an advanced care plan, state what they want to happen at their funeral within their funeral wishes document. They're able to log, as we've just looked at, all of their online accounts within a social media will, sometimes also called a digital will, and puts it all in one place. And once it's in this one place, and once you've completed you know, a certain section, so in this case, an advanced care plan form, you simply download the documentation and share it with your GP, share it with your loved ones, share it with your friends and family, print it out, keep it in a safe place to ensure that your wishes are met and that they're adhered to. Once a GP has got it, they can append it to your medical records. Once your friends and family have got it, it can open up a conversation. And then at any point, of course, you can come back and update your preferences and your wishes. So a final few things to think about. Think about what plans do you personally need to put in place to safeguard your digital assets and your digital legacy. How are the areas that we've explored today of relevance within your region and to the communities in which you serve and within the communities in which you live? And what barriers need to be overcome? So mentally, what barriers need to be overcome? If you don't understand the technological aspect and what you can and can't do in each of the different platforms, how can you learn about these things? So there's, again, when it comes to the learning aspect, the Digital Legacy Association for the public section has got a breakdown of different tutorials, for example, how to download your photos from Facebook, how to set up a Google Inactive Account Manager so that you can assign access to your Gmail account, lots of different things, but it's really important. It's a Pandora's box. You need to think about all of the online accounts that you've got, think about the assets of sentimental and of monetary value held within each, and then create a plan and decide what you want to do with each. So your homework is optional. I will not be checking. You can check your own homework, but ultimately think about your social media will. If you want to use My Wishes to do it, it's free. If you want to use the Digital Legacy Association, it's free. I'd recommend listening to Joan Bakewell's We Need to Talk About Death. Unfortunately, you'll hear my monotone voice in that as well, but there's some other great speakers in there that kind of that are well worth listening to. And I would like to finish by thanking you for your time and wish you all the best for the rest of Dying Matters Awareness Week.
I feel like I've been saying wow a lot this afternoon, but I think it's truly been just phenomenal. And this last presentation, James, I think more than ever after COVID, we have all understood the massive shift in terms of digital, and actually digital often only being a way to reach people when we've not been physically able to engage. And a couple of people have put in the comments, and I agree, having recently lost quite a few people over this last year, how important being able to see Facebook pages and how to still look at photographs and how to share in people's journey and family is so important. And someone's put here, Graham has kindly put, speeding bullet maybe, but you have captured the importance of the largest migration in history on all our assets, deaths and starting points for managing that. Somebody else has put, this session has been so informative. That's Vicky. And Karen has put, she'd never even considered it, but having lost her best friend, I understand the importance of being able to access her account on Facebook and seeing photos and messages and sharing this with each other keeps her close to me. Thank you for talking about this issue. I think it's great you've given us some homework, because I've got lots of questions that I would love to ask you, and I have no doubt that we will have you back again to just kind of perhaps go through all of this, and it'd be great to introduce you to some people where I know that this information would also be incredibly relative and relate to the way that systems are starting to shift across health and social care, and how we can all use these digital platforms more effectively. So thank you so much, James, and for bearing with us this afternoon in terms of the timings. Thank you.
No, thank you.
I just want to say, because we're 15 minutes over, but thank you so much to everybody who has been with us for the whole afternoon in terms of our timings. I haven't tried to stop people because I feel like there's been so much important information to get out there and to share, and all of the presentations are really in Dying Matters Week so important that we talk about it. Just a quick reminder of the hashtags EOL Cornwall and also hashtag DMAW21 for Dying Matters Week. And just to reiterate, everyone will get a copy of all of the answers to the questions, all of the presentations, and a CPD certificate. And what we want to do is see everybody here again tomorrow for the second of our sessions this week. Any other questions, please get in touch with Lolly or Tracy or the amazing team at Cornwall Hospice Care who put all this together today. And thank you very much. Look forward to seeing you tomorrow.